Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Robert Wood Johnson Foundation on making the business case for 618 interventions. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 3 moderated question and answer sessions during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Shilpa Patel, Senior Program Officer at the Center for Healthcare Strategies.
Hi everybody, my name is Shilpa Patel and I wanted to welcome everyone again to our webinar on making the business case for CDC's 618 interventions. Before we begin the webinar, I wanted to let you know that today's event will be recorded and shared. Today's webinar will provide information from different perspectives on building the business case for new or expanded Medicaid prevention benefits. During the course of the webinar, we will have 3 presentations that will provide different perspectives on the process of making the business case for CDC's 618 interventions. After each presentation, you will have the opportunity to ask our presenters questions related to their work. Although the questions will be answered after each presentation, we encourage you to send us your questions during the presentations so we can prioritize them. I want to acknowledge that this webinar will focus more on making the financial business case. There are different ways to make the business case for a new benefit or policy change. The financial case is one important aspect to address, but there are also other components. For instance, this webinar does not cover how to make a scientific ROI calculation, but how to more quickly project the potential impact of a Medicaid benefit or policy change and how to work with Medicaid to adopt and appropriately reimburse for the benefit. I would now like to introduce the presenters on today's webinar. Tricia Letty is a consultant for Faulkner Consulting Group and provides technical assistance to CDC 618 teams. She was formerly a senior fellow for the state health programs at the Center for Healthcare Strategies and has more than 30 years of health policy and state government experience, serving in senior positions in Rhode Island Medicaid and public health. Brittany Guerra is a health program specialist for the Utah Department of Health asthma program and has been with the program since 2014. She is responsible for health system strategy implementation, health system partner development, media and communications, grant coordination, and policy implementation. Brittany is currently serving as a board member in the policy unit for the Utah Public Health Association. Rebecca Owen is a consulting actuary with HCA Solutions and a former health research actuary at the Society of Actuaries. She has been in health actuarial practice for over 20 years with a particular focus on Medicare and Medicaid populations. I'd now like to turn it over to Tricia Letty for her presentation.
Hello, everyone. Can you go to the first slide, Travis? Thank you. I'm going to talk about how and why to make the case for a new Medicaid benefit. And a lot of times we talk about making the business case and doing the mathematical calculations, as Shilpa talked about. But I would say that finding the money is definitely an issue for having Medicaid add a new benefit to a program, because Medicaid has to come up with the dollars. They can draw down the federal dollars, but they have to come up with new state dollars, usually because in the first year there are usually not enough savings to cover the investment. So one thing to do is to first see if there are any state dollars that the state can invest that where Medicaid would be able to draw down the federal dollars, and it would be a partnership. So, for example, if the health department is already funding a service and wants it to be covered in Medicaid and is funding it for all populations, what funding sources are being used to fund that service? If there's general revenue funding that service, then that general revenue can be doubled or more by adding the benefit to Medicaid and the health department contributing the general revenue dollars for the state portion in the Medicaid program, adding that service to Medicaid and drawing down the federal dollars as a covered service. So it's important for us to look and see if there are any state dollars around that can be used to finance the state portion of the service. That makes it a lot easier for Medicaid. Next slide. It's important when you're presenting the case for a new benefit to present the case broadly based on improvements, expected improvements in access, quality, outcomes, customer satisfaction, as well as cost savings. In Rhode Island, when they presented their asthma program as a potential Medicaid covered service, they described potential gains in all areas, and as well, they presented it as a partnership where they offered to provide training as well as collecting data and analyze it in order to write reports on how the program is going to give Medicaid credit for its success in adding the benefit and whatever results would happen. Next slide. The evidence for success or savings can be gathered from a number of places, including published reports, as well as other state Medicaid programs who have tried to do the same thing. Everyone's usually willing to share. Or you can gather evidence on your own program, as Rhode Island's asthma program did, for example. They tracked the results by using claims data of program participants pre-program inclusion and then after the program was done, and found that that there was in fact a savings, but only for a portion of the population. When they first looked at the data, they said, well, it's kind of cost neutral. We're putting everybody in, all the kids in a certain age group that have a diagnosis of asthma, giving them this intervention, and our investment is about equal to our savings in decreased hospital use. But when they cut the data by saying, well, supposing we only gave this program to the highest risk in the group and didn't include everybody in the initiative and only included people who had 2 or more ED visits or hospitalization in the year prior to program participation, they found if they cut the data that way, that they had a very significant savings in decreased utilization. So then they pitched the program as a high-risk care management program for children who already had these high costs in their claims history. Next slide, please. So there's different steps, logical steps to gathering the information that to calculate first what the cost will be, the investment amount. And in Rhode Island's case, they tailored it to the high-risk members, so the costs were actually, the total costs were less than they would have been if they had counted all of the costs to the entire diagnosed population. So they were that made it more easy to demonstrate results. And as well, the higher risk patients usually have, the program usually have more of an impact. So this worked out well and they could demonstrate savings. Include both administrative and costs of the service, and figure out what it's going to cost on a per person basis, both in the current fiscal year and future years, by looking at the number of people and the cost per service, and come up with an annual cost of the program. The first year is usually the hardest to make a cost-effective case for. Next slide. Sometimes you can find true savings, meaning that you can really find real savings in a state expenditure area that, but usually savings come in what's called cost avoidance, meaning, well, this would have happened if we didn't do this initiative. So that's a little harder to prove. So you have to get your figures and documents all ready and say, okay, here's what the cost would have been by 1 year of pre-program costs, for example, and here's what it would have been afterwards without the initiative, and here's what the costs actually were with the initiative. So you can show the decreased expenditures from the investment and show savings. So that's how you count toward what's called avoided costs, which is usually the savings, which is usually how savings accrue. Next slide. And then it's important to look at where the savings will accrue. There are all kinds of savings that you could count to social service programs, for example, to education, to corrections. There's so many in adding a service to a health benefit. There are a lot of different areas of potential savings. But what you really want to focus on is the savings that would accrue specifically to the Medicaid program and their budget, because they're the ones that are, unless the health department has the state match available, they're the ones that are going to have to make the case to the legislature or the governor for this new state investment, which is a tough case to make in these budget times. So the Medicaid savings can accrue to either the managed care plan, if it's a Medicaid managed care program, or to fee-for-service, either one. And if the savings accrue to another program, then perhaps that state program can share in the cost if they're going to have a savings. But that's a tough case to make too, because everybody's under such budget constraints. Next slide. So the next thing is to help to strategize the state's approach to really moving this forward. If the health department has savings, has some state money to share, then that would be a great way for the program to be started off at least, and Medicaid could contribute the federal share. Often, if there's new state money needed, it's a very visible thing, needs to go to the legislature or the governor. And sometimes a savings can be presented not as a request for new money, but as a savings initiative. Every year, the governor is looking to Medicaid for savings initiatives, and to every department. And if it can be posed as a savings initiative, and the documentation is there, and the argument can be made solidly, then it might be that it goes in as a required savings initiative. So that would be a really good strategy to try. And otherwise, make the case that the program will at least pay for itself, if not save money in the long run. Next slide. Sometimes adding a benefit means that there would be a savings to the health plan, which would be a savings to the state Medicaid program. So, for example, in Rhode Island, before all of the additions to family coverage that came in the throughout the 90s, the program added postpartum family planning coverage as an ongoing benefit for 2 years for postpartum women whose babies stayed on Medicaid, but they lost eligibility. And it was proven that that this decreased the number of births and associated public costs. This really convinced the legislature that this benefit was worth it, and helped to expand the program to broadly to postpartum women and to parents. So if savings can really be documented across many programs, the state can can decide to use those savings to add PMPM, or per member per month dollars, for the investment, and then the decrease in expenditures in PMPM to the health plan would be proven through data collection and analysis. So net savings would be achieved through a net decrease in the per member per month fee that the state is paying to the health plan. Next slide. If the change, the new benefit or change in benefit, such as change in a prior approval or a copay, is going to require a partnership with the health plan, it's really important to ask for their help in in implementing and tracking the investment in savings, and to really get them on the same side as far as seeing the problem and trying to focus on a solution. So it's important to really document whatever you're trying to do. If it's, let's say, adding a benefit or taking away a prior approval, what is the reason what is the reason for this? What access problem is it causing? What is the problem that you're trying to solve? And if you can really logically present the data to say that, yes, this is a problem, then that really helps. And if you can't make that case, then one idea is to suggest to the Medicaid program that they use this problem that you're presenting as an EQRO topic, which they're required to pick topics every year, quality topics, and an outside firm comes in and looks at the data and at the health plans and sees if in fact it is a problem, and then works with the health plans to find solutions. So an EQRO study can help document whether or not something you think is a problem really is, and really gets the health plans on board with trying to solve it. And it also provides the plans with the opportunity to help solve the problem. It could be that exactly what public health thinks the solution is might not exactly be the best solution. And it could be that you've identified the problem, but that the Medicaid program and the plans might have different ideas for solutions. And it's really important to listen to that, because they have a lot of experience with trying to make the benefit the best it can be. Next slide. So in summary, it's really important for everybody to get on the same side of the table: public health, Medicaid, and the health plans. So public health can have a really big role in identifying the problem. Maybe they're finding out about a problem, an access problem, from a hotline they have, or from complaints, or whatever it might be, some data collection method. And they can help Medicaid make the case to gather the data, document the problem, and look for evidence-based solutions in other states, for example, or maybe the health department has found a program or a service that they have found helps this problem, and they can document the success. Medicaid can help make the case to add a new expenditure or make a new investment, which is always a tough uphill battle, by looking for a reliable general fund revenue source or savings offset. So other general revenue fund, other than, say, for example, if the health department has some general revenue funds that is already paying for a public health funded service that could be invested, and the money can be doubled or more with Medicaid. Perhaps there becomes an issue I talked about the first year investment, and that the savings aren't going to accrue until the second or third year. In that case, can the health department and Medicaid partner to maybe go to a local foundation and see if they would make a 1 or 2 year investment just for the upfront investment, and then continue the program through the savings. So there are a number of different funding sources that can serve as state match, not just legislated general revenue funds. It could be fees, taxes, or even foundation money. And the health plans can get really involved in helping to solve the problem, because they have a lot of experience with trying to make the benefit the best it can be, and they really want to satisfy their customers. So bring them into the conversation, make it a real partnership, see what each party can add, and try to keep the members at the center of the table. And if the members are at the center of the table, not a particular program or a particular provider that you're trying to use, if it's really the members' problem that you're trying to solve, then and you express it and document it like that, then everyone will come to the table to try to solve the problem. Thank you.
Thank you, Tricia, for your presentation. I'd now like to open up for questions for Tricia. As a reminder, to ask a question, you can click the Q&A icon located at the bottom of your screen. So Tricia, we actually had a question come up as you were presenting that was specific to the Rhode Island example that you highlighted during your presentation. So for the Rhode Island example, were there cost savings associated with comorbid chronic conditions, or was it just related to asthma?
Just related to asthma. They looked at decreased ED visits and hospitalizations with I think a primary or secondary diagnosis of respiratory, something like that. So it was, they didn't look for comorbid savings.
Okay. Thanks, Tricia. Another question that we had for you is, what are some of the steps a team should take after completing an ROI analysis?
Oh, well, that's a good question, because the first thing is to really look at the results. They don't always come out the way you want them to. So in Rhode Island, for example, when we looked hard at their results, it came out to be cost neutral. And so that's when we came up with that idea of, well, okay, are we going to make is Rhode Island going to make the case that this is a cost neutral program and Medicaid should invest in it? And instead, they looked at what other states had done, and some of the other states had restricted the program to more of a high-risk, high-cost population. And for a care management program of any type, of any diagnosis, that usually works in that if you tailor the program to the high-risk, high-cost, you're going to get more savings. So when they split the analysis and said, if we had applied this just to the people who had high costs associated with their uncontrolled asthma, would we have then seen savings? then they found the savings. So first, look at the results and see if there is a way to not just take the program as you did it, but to really see whether there is a very effective program within the program that could be found and proven.
Thank you, Tricia. That was super helpful. So we're now going to turn it over to Brittany Guerra for her presentation.
Hello, thank you for this opportunity to present with you today. My name is Brittany Guerra. I'm with the Utah Asthma Program, and I'm going to talk with you a little bit about our experience in the 618 initiative in last year's cohort. So our main reason and goal for joining the 618 initiative was to seek expansion of our Utah Asthma Home Visiting Program, which is a program that addresses self-management education and trigger education in the home for people with uncontrolled asthma. And we were hoping to find ways to establish sustainable reimbursement and coverage for this program. Part of that, we wanted to develop our return on investment for the program. We wanted to explore any opportunities for funding that would be feasible in our situation here in Utah, and build a better relationship with our Medicaid program. So just to give you an idea of what the intervention is itself, our home visiting program is a 3-visit program where we go over, in the first visit, we go over what the asthma symptoms are, as triggers, medications, and inhaler techniques. Second visit, we do a walkthrough and talk about what triggers are in the home and how they can reduce those triggers. And then the third visit is to discuss progress on achieving their goals and on achieving control. So the program was initially begun in January 2016. We've had 250 patients enter the program and 205 have completed it, which means they've done at least 2 of the 3 visits. The program is offered by specially trained health educators in 2 of our local health department areas. In 2017, we looked into providing the program through clinically supervised, specially trained community health workers in Salt Lake County, and we're currently evaluating that pilot to see how it turned out and if that's viable in the future for us. The home visiting program is more effective if it occurs in the children's day-to-day environment in order to assess and suggest changes and interventions such as dust, bed linens, rugs, pets, and smoking, for example. So we've seen some great results through self-reported data. So far, these are some of our results that have happened just in the first 3 visits or even after. We've seen that there's been improved asthma control test scores, that improved control has been sustained over the next year, that we've seen an increase in the use of their controller medication, which is important for controlling asthma. And then we've also seen increased confidence managing asthma, which has all been really positive results. We've also seen reductions in unwanted and costly events related to healthcare. So as you can see here, we've seen reductions in average missed work days, missed school days, unplanned doctor visits, episodes requiring an oral systemic corticosteroid, asthma-related ED visits, and also asthma-related hospitalizations. And we're really excited about these outcomes and to see how we could use that in seeking sustainable finance. So here you can see this was part of our fact sheet that we put together with a lot of support through 618 and through some national partners, including Tricia Letty. Thank you so much for all your help. But this was a way that we developed our ROI. So initially, we calculated our ROI based off of ED visits reduction alone. We were able to get the average asthma ED visit cost and then compare that with the reductions and also our calculated program cost per participant to get an ROI of, for every $1 invested, $3.31 saved. This was a beginning ROI. Something we learned is that as we're calculating ROI, this is just including ED visits, and this is based off of a cost for the program that we want to keep evaluating and making sure is really sustainable. And so this was a start based off of self-report data that we hope to replicate in the future and to include more of the cost savings that we already are anticipating to see based off of our preliminary results. The ROI is evolving for us, is what we're learning. And we're hoping in the future to match this to actual claims data so that we can show a true cost saving. So some of the supporting partners that were critical in our process with 618 is we were able to develop a 618 internal work group and coordination around the projects that were chosen, which was asthma and diabetes last year. And that included Medicaid representatives, which really helped us get at the same table, like Tricia was talking about. We had our funded providers for the home visiting program, which was our local health departments, and we also included our legal departments to figure out the things we needed to get in place in order to share identified data and to be able to match things in claims in the future. We've involved our data stewards at the health department, which is our Utah Office of Healthcare Statistics, and also Medicaid analysts to help us with finding the cost data for the average asthma ED visit cost data versus charge data. That gives us a better number to work with in our ROI calculations. And then we also took full advantage of the TA provided through 618. We had a lot of really wonderful national partners willing to help give guidance in our fact sheets, our business cases, see examples from other states, and review our analysis as well. So I was very grateful for the support that was offered through 618. So what we did, we set up our 618 work group internally here at the health department. We figured out what we were focusing on, and we explored what options were available to us here in Utah based off of all of the wonderful examples we got from other states to see what really could be done here in Utah. One thing that we explored was leveraging the EQRO process to see if that could be something we could work with our Medicaid quality program and see if we could get asthma in there to help promote the home visiting program. And at this time, we decided not to go forward with that, but we do really appreciate CHADAC and all the work they did to pull together reports for us so we could explore that option. We talked about the 1115 waiver, we talked about CPT codes, and at the time, the guidance that we got through 618, pulling us together with Medicaid, was what we should do is prepare a really solid pitch to the Medical Care Advisory Committee, which is a group of individuals who provide recommendations to Medicaid leadership on what priorities they should consider in their budget. And so we decided to focus our efforts around preparing for a presentation to this committee June 2018, using the outcomes that we started to get, our ROI, and the asthma burden that the asthma burden argument that we were starting to develop. At the time, we explored how we could possibly open certain CPT codes to meet the need of the need that we needed for the cost of a home visiting program, self-management education, et cetera. And it was really helpful to have access to national reports done by American Lung Association on what was currently covered here, so we could use that as well in our conversation. So we pitched our request to the Medical Care Advisory Committee and ended up getting ranked 9th out of 19 requests, and that was enough momentum at the time to get this request for opening CPT codes to our upper leadership, and they ended up inviting us to apply for the state block grant funding for this year. And so we ended up doing a completely different ask, but it opened the door for us to even have that opportunity to apply for state block grant funding. And so this application had us asking for $80,000 for one FTE in a rural or frontier county to set up the home visiting program, and with federal match dollars, that would actually be $160,000 for 2 FTE. This was coming out of the Medicaid administrative budget, and we got it, at this point, it got approved by Medicaid leadership, the state health department leadership, the governor included it, and now it's in the process of getting approved, hopefully by the legislature. So we'll see how far it goes, but we were just grateful to even have that opportunity open to us based off of the other avenues we explored. And we got a lot of support from 618 to even look into that. So we're still looking into matching our self-report data with claims data and looking maybe into using the match model if we're able to show that there's a cost savings for our medical care organizations, our managed care, oh my goodness, our MCOs. We've looked into pay for success, and we've looked also into additional grant funding from the CDC. So I think the 618 process really gave us the great infrastructure and upper leadership support to pursue some of these opportunities we didn't have the opportunity to do before. We really appreciated the in-person meetings and peer-to-peer calls and all that relationship building that it facilitated. And we appreciated the national expertise that also gave us examples of business cases from California or fact sheets from Rhode Island or other things to work off of to put together our talking points for our pitch. So that is what I had provided for you right now. And we're open to questions.
Thank you for your presentation, Brittany. So So I'd like to open it up for questions for Brittany and Utah's work as part of the 618 initiative. And I also wanted to note that we have two members of the Utah Medicaid team, Nelson Clayton, who is the Manager of Quality Programs for Utah Managed Healthcare, and Matt Ahern, who is the Assistant Director for Managed Healthcare, on the line as well. And they can definitely answer some questions from the Medicaid perspective about the work under the 618 initiative. So the first question I had, and I think it's specific to Matt and Nelson, so from your perspective, what were the most effective aspects of the business case that the Utah Department of Health presented to you?
I think that the most effective part for me was I saw this program as kind of like a research university that is developing something. And there's not a lot that the MCOs would have to do to take on and utilize this resource and manage and check to see if it's effective. So a lot of the hurdles that Rhode Island talked about in terms of investment costs that are up front, that's something that our public health department already had. So there were no huge startup costs. There were no fixed costs associated with hiring those specialists. There was just the ability to refer people to the program and then measure after that. So I think it was a really elegant way to kind of bring the MCOs along into evaluating the effectiveness. And, you know, for the managed care side, the plans really have a lot of leeway in determining what they can do, how they can intervene to help patients. So to me, that was a huge benefit of the Utah program.
Great, thank you. We had another question come in, and someone wanted to know, can you explain the self-report aspect of the ED visits for calculating ROI?
Yeah, so with our program, we have our health educators collect a lot of data from the participants, and this is how we were able to showcase those outcomes that I shared. With our ROI, we were only considering asthma-related ED visits, and in the intake form that we have participants respond to, we ask them in the previous year, how many asthma-related ED visits did you have? Or if it's for the child, how many did they have? And we also ask all those other questions about hospitalization, corticosteroid use, et cetera. So we ask that at intake for the year prior to entering the program. And then we ask on the 6-month follow-up call. So we have 2 follow-up calls, one 6 months after they complete visit 3 and one 12 months after they complete visit 3. And the 6 month is just in case we can't get a hold of them 12 months later because people move or change their phone. But really the 12-month follow-up call is what we aim for, because that's a full year after completing the program. We then ask them again, how many ED visits did you have in this past year related to asthma or hospitalizations, et cetera. And then from there, we're able to calculate a reduction in asthma-related ED visits, and that reduction is what we use in our ROI calculation at this point. We're hoping to do more robust calculations, including hospitalizations, the corticosteroid costs, the unplanned doctor visits and urgent care visits, et cetera. So.
Great, thank you. So another question that we had for you, and one that comes up frequently during the 618 initiative, is the length of time that it takes to make a benefit change. So can you describe your experience with the length of time it took from developing your business case to presenting it to the Medical Care Advisory Committee, especially since budget decisions are made from year to year, and where and when you saw progress or momentum from those efforts?
So we've really started to see progress after this last presentation. We've been working on seeking sustainable finance since we were funded in 2014 by our CDC grant. We just haven't had the right avenues or opportunities to see real progress. But I think 618 really did provide that structure and opportunity to talk about real options available and to get the information out there in front of the right people so that we could have an opportunity to even pitch for this state block grant funding opportunity. We still don't have any other funding currently there. We're just excited about the opportunity to get closer to that conversation. That's what I have. Do you guys have anything to add? Yeah, so it's been about 1.5 years of some exciting work.
Great.
But still hasn't resolved. So we'll see what happens.
One more question we had come in is, are you able to leverage your business case learnings to inform 618 program progress monitoring?
So I will say with our state, we decided this was a really valuable work group that we established with our Medicaid representation, public health representation, and some other representation from our UDOH leadership. And so we decided to continue meeting, even though we're no longer part of the cohort, to work around the 6 chronic conditions and 18 interventions. And we've talked about monitoring progress of the 618 work group and how we could better track success of this work group for the programs, as well as just overall state priorities, including population health priorities and related things. So I don't know if I'm answering your question at all, but we definitely have used the progress we've been able to achieve through 618 and the TA support to kind of mark where we're at least with our asthma efforts, but we're also looking at 5 other chronic conditions and how we're approaching them. Do you have anything to add to that?
I would just add that we're thinking about inviting our ACOs into the 618 process so that it's collaborative, not just with Medicaid and public health, but also the plans that put things into action. So
it seemed to me, this is Matt, but it seemed to me that part of the process as they were going through to build the business case was kind of narrowing their focus in what they're looking for, what they're trying to accomplish. What are the sorts of things that are possible to get from Medicaid, what aren't, and what would you have to have in place. And I would imagine that process in and of itself would inform the development of additional programs and kind of narrow the focus on what we need to look at for the to show the ongoing success of the initiative, because it's kind of tailored to the narrowed objective.
That's great. We're very excited to hear about that. So thank you again, Brittany, Matt, and Nelson, for your presentation. And I'm going to turn it over to Rebecca for her presentation now.
Hi, everyone. Thank you so much for including me in this call. I've been involved with 618 for several years now, and I'm just really excited about the sort of opportunities that these programs offer to beneficiaries to have better health. And but actuaries, we have a way of looking at things, and so today I'm going to go over this. So before I begin, like every actuarial communication, I'm going to tell you about what it's not good for and to be careful. So this is pretty high level. It'll vary by your state, it'll vary by your program, and it'll vary by your MCOs. There'll be all sorts of rules that you'll need to be really careful about looking at as you try to explain to the actuaries who are setting your rates or the actuaries who are receiving the rates how your program would interact with the Medicaid in your state. And we have to follow rules. And the managed care manual is 1,425 pages of exciting reading. But more than that, we have standards of practice, and we have rate setting guides, and we will probably have rules from within our organization. But it all comes back to this whole question of actuarial soundness. And when actuaries think about actuarial soundness, they want their calculations to be reasonable, appropriate, and attainable under the terms of the contract offered, for the time period that the contract covers, and the population that it's intended. So that's a really big shorthand for the whole construction of rates. And in the next few slides, I'm going to go over what types of change we think about and how we would incorporate things like new initiatives from 618 organizations into our rate structures for either planning or accepting rates. So first, some jargon. If you're a managed care organization, and I'm sure most of you will understand this thoroughly, the state usually, not always, because Medicaid varies from state to state, the state will say to a managed care organization, we'll pay you a capitation member rate per member per month, and maybe we'll carve out hepatitis C drugs, or maybe we'll carve out behavioral health, or maybe you're going to start covering community-based health services. But there'll be a very explicit contract that says what's included. And that has to cover it all. And it includes margin, which sounds like a dirty word, but margin, especially for nonprofit organizations, is the money that you put in savings for flu epidemics or unexpected costs. And all of these rates would be adjusted by the program. So for instance, the beneficiary category or what's included, probably by geography. So if in your New York State, costs for Albany do not look like costs for Manhattan. And by age and gender, so older people tend to be more expensive than younger people in general. And often there'll be a risk score which talks about chronic disease prevalence and expected costs within the program. So as your organization starts to look at things, they're going to ask this question, I'm sorry, I've skipped ahead you're going to ask the question, how does my delivery system, the types of changes that are happening. So maybe you're going to add a benefit, and in which case they have to understand how things might shift around from other benefits. You might want to change a benefit, make it thicker or thinner. You may want to say that different kinds of providers can do these services, and maybe you're asking the MCO to change the way it administers the benefit. So that'll be something that an MCO and an actuary will think about. But the real big questions start in this whole, how does your population compare? So all of these PMPMs are pretty much average, but your demographics might be different. You might have more rural hospitals. You might have access to care or community issues, or you may discover that the idea of using contraceptives, for instance, might be different between your populations, so that your expected outcomes on doing a post-delivery savings due to family planning might be different for your population than a national average. There may be more of certain kinds of diseases that aren't contemplated in the risk scores that are specific to the subset of the population that you're insuring. And so often we're given studies from other states, and we need to think, how do I adjust this study from other states or from other populations or from public health studies? How can I adjust this so that this particular study matches the population that I'm looking at, either covering through Medicaid or accepting the contract through my organization? Then, so delivery systems are different too. And I want to, at this point out that actuaries work for the state and actuaries work for insurers, but actuaries also work for providers now that delivery systems are starting to accept risk. So an example is if you have a large ACO that's accepting upside and downside risk, in other words, they're going to take on all of the costs for an expected patient, they're going to want to understand how their population looks like compared to the proposed capitation that the health plan is offering them. There may be questions about if a MCO has developed a particular type of network. So if you have something like Kaiser, your Kaiser network will determine how your programs are going to be implemented and where the cost savings are going to happen. Whereas if you have a more open network, you may be able to affect some of the changes more quickly with parts of your network, but not your entire network. And another problem is that we've got this time to program maturity. So the benefit is suggested, but then we can't get it in place automatically. There'll be time to redo the contracts or to maybe get staff or to change administrative policy. So the actuary thinks, okay, how fast can this be implemented into the overall experience so that we can estimate what the cost savings are going to be. And always we need to think about how pharmacy fits in. And then there's all these things about how your company works. Your company may not be the same as what happened when the model program was put in place, and you'll think your way down through this list. So the worry is, okay, what if I'm not accurate? And the answer is, of course, you aren't going to be accurate. You're an actuary dealing with uncertainty, and you're probably not going to make a perfect estimate. So maybe the program changes are small, and there's not a lot of premium at risk, and you can be relaxed. If there's a whole lot of changes going on during the year, you want to be careful, because sometimes there are unintended consequences when 3 initiatives interact. And then there may be other risks going on. So an example would be if you had an asthma program and you were estimating savings for asthma, but you happen to have a plan in Southern Oregon where there was also increased wildfire risks, then you'd want to be really careful about measuring asthma-related emergency department visits in the middle of wildfire season. So, and then there's always the question, how will you know when you're is a success? So that's how we think. That's what we think about, and I am happy to entertain any questions that you might have.
Thank you, Rebecca, for your presentation. I'd like to now open up for questions to Rebecca or actually any of our other speakers. And as a reminder, to ask a question, you can click the Q&A icon located at the bottom of your screen. So our first question is actually for Rebecca. What are the key challenges actuaries face when approached by a state about incorporating a new benefit to managed care rates? For example, do you have issues, or do you see issues around timing, incomplete data, or other factors?
So yeah, thank you so much for that question. So of course, the timing one is the one that people most often know, that often public health initiatives involve an outlay today, and the savings will be recouped in 3 years, but you're receiving annual rates. So the timing issue is really well known, and there are some studies to help us figure out how quickly this happens. But another thing might be that if we have contracts for unit costs which are different than the program estimated cost savings unit costs, our results may be totally different, and our margins are very small, and so we need to redo all the calculations and see if they line out. So information may not align with past experience. Current situation may not align with past experience. I will say the more you tell us, the more likely we are to be able to figure out how to make it work.
Great, thank you. Our next question is actually in follow-up to something you had mentioned, Rebecca, and I'd also ask Tricia to also chime in. But what advice would you give a state that cannot demonstrate short-term savings for a given prevention strategy, but rather can make the case for a longer-term savings or for a positive impact on beneficiaries? So Rebecca, yeah,
that's such a hard question, because if it's in a Medicaid population where the membership is sticky, so for instance, the disabled population is more likely to be sticky, or if you have regional plans which are long and persistent, you can argue that this is an investment in the future. So you might look at the type of population and whether or not the managed care organization is likely to be the insurer in the future as well as today. That would be, just make sure you know what that is. And but if you have a churning population, you're going to have to think of an alternate argument. And I'll let other people chime in on this.
So one alternative solution might not work for everybody, but it's an idea, is that, you know, most states have local foundations. Some of them formed when, like hospital conversion foundations or whatever, that can sometimes provide temporary funding for something, but not ongoing. foundation funding can be used as legitimate state match for Medicaid. So if it's a 1 year, a 1.5 year, or even 2-year issue, the Medicaid program and the Public Health Department together proposing such going to the foundation and applying for funding to jumpstart the program might really work.
Also, if you have nonprofit managed care organizations who have community dollars, you may be able to talk to them about those.
Yes.
Great, those are great suggestions. Thank you. Our next question, I think also for Tricia and Rebecca. During the 618 initiative, we've had an experience where a few states were interested in the financial implications of removing access barriers, like small copays or prior authorization requirements. What advice would you give to states that are focusing on these efforts, and how would a state's approach for removing a prior authorization requirement differ from that of adding a new benefit or covered service?
I could take it first, Rebecca, if you'd like.
Why don't you, Tricia, and I will step in after.
Okay. Well, one thing is to show why does the Public Health Department think that copays or prior approvals are a problem. If the Medicaid or the health plan don't see it as a problem, then they won't be invested in trying to find a solution. So really documenting why there is a problem, I think, is the first thing. Many health plans might say that a small copay for something like tobacco cessation classes is something that keeps people invested and coming to the classes. So there are arguments both ways for small copays, for example, such as things that require commitment. So really, I think starting with how do you know it's a problem, and then going for once you can document it, asking the health plan and Medicaid for help in achieving a solution, not necessarily the one that you think is a solution, but a solution to the problem.
I'll chime in on prior authorization. So one of the things that you'll want to see if you can help is to show whether or not prior authorization has an actual impact, or if it's just providing a sentinel effect, or it's not really doing anything. So finding out that the prior authorization approval rate is 95% goes a long way to discussing whether or not the prior authorization is important or effective. Another thing is to think about having some providers goal carded. So instead of eliminating all prior authorizations, suggest that there's a subset of providers for whom either some sort of performance objective has been demonstrated, or that are willing to be involved in the program in some really developmental capacity, that those prior authorizations are relaxed, and so you can sort of inch your way into dropping a prior authorization.
Great, thank you so much. So we are actually just about at time. So I wanted to thank you to our presenters for your amazing presentations, and to the Robert Wood Johnson Foundation for their support, and to all of you for participating in our webinar. So just a few reminders before we end. First, please visit the 618 private portal on the CHCS website for resources and tools related to the 618 initiative, as well as other practical and relevant information. And second, please complete the brief online evaluation that will pop up on your screen. As Travis mentioned, your feedback is really important to us, and we hope that you'll take a moment to fill out the evaluation. So thank you again for everyone for participation in this webinar, and I hope you enjoy the rest of your day.